that have joined from outside the country, from the UK, from Canada, from the United States, and I'm told some from Australia. We welcome you to this sector-wide webinar organized by the Federal Ministry of Health and Social Welfare as part of its advocacy, enlightenment, and capacity building for everyone in the sector and all the friends of the sector. So on this note, I would like to ask the moderator to introduce the presenter. But if the DHS is online, she can come up and make a remark. Otherwise, she will make it after the presentation. Please, happy listening. Thank you very much.
Thank you, the Permanent Secretary Designate, Dr. Camille Shure, our boss. Thank you for giving that opening remarks and also declaring the events open. We warmly also welcome all the directors on the call, the chief executives, the director generals, and the MDs of our respective departments, agencies, and parastatals under the Ministry of Health. And also want to recognize colleagues who have joined the call, even within the country and outside. Welcome. We want to quickly, before we have the keynote speaker on board, we want to quickly give us some key rules, ground rules for today's session. We want to quickly tell us that we would need to respect each other's opinion. Use the raise hand button on the Zoom call if you must speak, but we sincerely do encourage us to use the Q&A session to put on our questions and comments to the presenter accordingly. So we also want to highlight that if you have any technical issues, kindly reach out to the team, and this Zoom will be recorded. Do well to accept this. If you must remain anonymous, please rename your device, but we encourage us to name our devices to reflect our respective organization. My name is Dr. Eko David Iam. I will be moderating today's session along with Dr. Dozie Nwokedi, who is also on standby to anchor this session for us. They're asking us that we need to take the opening prayer, but then I think the PEMSEC designate, with your permission, we will just recite this and then we'll introduce the keynote speaker. With a count of 2, we'll just recite this together. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed. Thank you all. Next slide, please. We'll just quickly take the citation of our keynote speaker. Dr. Dozie, please, over.
Sorry. All right, thank you, Dr. Eko. Thank you for the opening remarks and the anchor. Can you hear me?
Yes, please. Louder.
Okay. All right, thank you. So today we have a distinguished personality who will take us on the presentation for today. And he's the current Registrar of Nursing and Midwifery Council of Nigeria, Ndagi Alhassan. He was born in Niger State 50 years ago, and he had his primary and secondary school education in 1984 at Kotangora. He commenced his professional nursing education training in 1985 at Bida, Niger State, before proceeding to Kaduna Polytechnic for his nursing education. He also bagged a Bachelor of Nursing Science from the National Open University in 2012 and went ahead to do his Master's in Nursing in 2021 from Babcock University, Ogun State, and proceeded to bag a Doctor of Philosophy in Nursing Science from Maryam Abacha American University in Maradi, Niger Republic in 2026. He has held several professional qualifications and is registered with Nursing and Midwifery Council of Nigeria as a registered nurse since 1988 and has also been a registered nurse educator since 1999 and a registered public health nurse since 2022. He started his nursing career as a clinical nurse at Wadata Clinic and Maternity, Bida in 1988. In 1992, he was promoted. He proceeded to the IBB Specialist Hospital in Niger State as a senior nursing officer and a nurse educator. He's also a member of the governing council of the Kaduna State Nursing Science. He was also the chairman planning committee of the 16th Biannual Nursing Leaders Conference, Abuja. He has worked in various places and distinguished himself in various roles he has played across the nursing and educational sector. In 2001, he rose to the position of Director of Nursing and head Inspectorate Department based on his wealth of knowledge and experience. He was serving as a capacity before he was appointed the Acting Registrar and Chief Executive Officer of the Nursing Council on October 4th, 2024, showing a testament to his confidence and hard work and the roles he has played to take the nursing profession to a greater height in Nigeria. He was confirmed the Substantive Registrar and Chief Executive Officer of Nursing and Midwifery Council of Nigeria on 19th May 2025, which he currently still occupies the position. He has attended several workshops and seminars and conferences, both at national and international levels, and has several awards, certification, and recognitions to his name from various organizations. He's married and blessed with children, and his hobbies include reading, academic research, and traveling. Distinguished ladies and gentlemen, please let's welcome Ndagi Alhassan, a distinguished scholar, nurse by profession, the current Registrar Chief Executive Officer, Nursing and Midwifery Council of Nigeria. Thank you so much. Okay, so for our presenter today, unfortunately, he's engaged in a professional and national assignment currently. So he's being represented by Assistant Director, Nursing Sciences, Dr. Ndagi Ayola, who is standing for him to take his presentation. So he has given the presentation to Dr. Ayola, who will take the presentation for him. Dr. Ayola Ndagi, you're welcome, ma. Please, you can unmute yourself. Thank you. Okay. Sorry, I understand now that Dr. Ndagi Alhassan is on the call currently. That's the Chief Registrar, yes. Nursing and Midwifery Council. Sorry, sir. Can you hear me?
Thank you.
Okay.
I can hear you.
All right, over, sir.
Thank you very much. The Permanent Secretary, Dr. Shetere Khalil, the Director, Hospital Services, Dr. Mrs. Adegweke, the moderator, and all the distinguished personalities on the web. Good morning. It is my pleasure to speak with you on the topic bridging the gap, bridging the theory and practice gap. Sorry. Okay. Bridging the theory practice gap, strengthening nursing education, CPD and evidence-based practice. I want to start by appreciating the Federal Ministry of Health, and in particular, the Coordinating Minister for Health and Social Welfare and his able directors, including the Director of Nursing Services, for giving me the opportunity to speak on the topic. The topic we are about discussing this morning looks, or on hearing, seems simple, but very strategic and critical. The choice of this topic may probably be informed by the necessary actions taken by the Federal Ministry of Health to get a feedback and then re-strategize towards efficiency. The Federal Ministry of Health on annual basis organized joint annual report on sector-wide approach. The formation of the team may be as a result of the outcome of the report from such a gathering, or by the report that is being received on daily basis on the performances of the nurses in the clinical site. The topic emphasizes on competency, and it may be due to the fact that there is lack of patient satisfaction, or the safety of the patient is endangered. The topic
Sorry, sir.
speaks
Sorry,
a
sir,
lot
for cutting
about
in.
competency, and all that your competency is talking about is the education, skills, and the function and the attitude of the nurse with the patient. Since by these qualities, probably the newly appointed nurses or the existing nurses' performance is not meeting the requirement to the safety of the patient or endangering patient life. Now that we want to look at it, let us take the outline of the presentation like this: introduction of theory practice gap, its implication for patient safety, causes of theory practice gap, impact of strengthening nursing education on the gap, then how continued professional development narrows the gap, and evidence-based practice, a tool to bridge the gap. Next slide. Next slide. Mr. Moderator, can I have the next slide? Hello? Hello? Hello?
Can you see the slide, sir?
I don't know whether it's hearing me. It's off. It will not tell them place. Something's covering it. Okay. He's trying to bring up the he's back. Now, like I said, that, sorry, the something is still covering. How do I?
Is on.
Progress. Okay. Nursing education is a complex interaction of theory within classroom and clinical settings. The support of learning in practice is essential for both preparation of new practitioners and ongoing continued professional development of existing workforce. Nurses learn in a variety of contexts and draw upon a wide range of knowledge and skills to prepare and engage in clinical placement. Therefore, there is a need to bridge the theory-practice gap in order to improve patient care outcome and achieve universal health coverage, thereby strengthening Nigeria's health system. Next slide. The key strategies needed to bridge the theory-practice gap include facilitating supervision, effective precepting, promoting evidence-based practice, addressing resource challenges, and encouraging professional communication. Now, the theory-practice gap. The theory-practice gap represents one of the most pressing challenges in nursing education worldwide. It is defined as the difficulty of applying classroom-acquired theoretical and research knowledge to real-life clinical situations. It creates barriers to developing competent and confident nursing professionals. This gap has wide-ranging consequences, from reducing the quality of nursing care to undermining students' professional identity. In essence, all that we are trying to bring out here is that the theory-practice gap is a common challenge worldwide, and it is because of the difficulty of applying the classroom-acquired knowledge and research studies to real-life clinical situations. It becomes difficult for the newly employed nurse to exhibit competency and demonstrate confidence in what he or she is about to do. And to that extent, it is very necessary that the likes of those nurses, there should be a pattern of how to supervise either the student or the newly employed nurse, or by extent, even the nurse that is deep into the practice. In the introduction of new technology or managing new cases, sometimes find themselves difficult to fit into the system to practice effectively. And to that extent, it's not a question of number now that is available, but the quality of service that is going to be rendered by the person on ground. Those are matters related in this theory-practice gap. Next slide. Manifestations of the gap. How do you identify them? You simply see that there is difficulty translating classroom knowledge into clinical decision-making, limited competence in critical nursing procedures, inconsistent application of nursing process, reduced ability to apply evidence-based care, and dependence on outdated clinical routines. Like I said earlier, the knowledge acquired in the classroom is theoretical, and during the training, students are exposed to clinical sites, but as an observer or supporters to the clinicians. At that time, the practice is limited, but because they have to meet the training needs, at some certain time, they have to perform some certain procedures to a required number to justify that they have acquired the skills. But because it is not regularly practiced, there is lack of perfection. And to that, you see that in a critical situation where now is a standalone, taking responsibility by yourself, the performance of such critical nursing procedures becomes a challenge. Oh, how can I do it? Can I measure up? What is the likely reaction of this patient? We have situations where people who sometimes train elsewhere don't even have a real life situation in their practice. Now that they are left alone to practice on their own, it becomes difficult for them to be able to practice effectively. So sometimes we have this nursing process, a way of managing the patient, individualized care, from identifying the challenges of the nurses of the patient, planning to effectively manage that patient, and persistent or consistent monitoring and evaluating the procedure. Because the person is no more under any tutelage, he finds it difficult. Sometimes at the beginning, he or she makes mistake, or as a student, when they are allowed to do it by themselves, there is this common mistake that, he assumed by this that this could be this, but then in the real life situation, that may not be the ideal. Therefore, it led to reduced ability to apply evidence-based care. The existing nurses or the clinicians in the ward, because sometimes they are not exposed to the new technology and it is being brought in to be used for the patient management, they are new to it, and what they are used to before is not similar to what they are seeing now. It becomes difficult for them to be able to apply the new knowledge or skills in helping to solve the patient's problem. Next slide. What are the causes of theory-practice gap? The cause could be seen in different ways. We have the educational system factors, we have the clinical factors, and then the how CPD could help solve some of these problems. But let us look at the causes of the theory-practice gap in educational system. The factors are not limited to, but one, poor interpretation of curricula by faculties. This is one of the commonest challenges. There is a national standard set in line with what the country wants to achieve. The curricula as designed by the regulating authority, sometimes in the course of interpretation, the faculties are not usually able to bring to the table the expectation, and that is why equally the CPD studies by the faculties too is very necessary. By assumption or in a regular way, that people will just depend on existing ways of doing things. What they were taught in the early 80s, still in the new era, in this technological era, they think that the knowledge of the past could still be used to interpret what is expected of them in this new era and misguide the student or the clinician who is mentoring the new employee, find it difficult to use the new knowledge to interpret the content of the curriculum. Limited integration of emerging healthcare technologies. Like I've said, we all know that process of learning moves from simple to complex, and in the process from cognitive to comprehension and integration, where you will do the integration of knowledge with the new technologies based on your old knowledge. Sometimes it doesn't match, and as it does not match, it becomes difficult for the clinician to use it in mentoring the younger one, or the younger one finding it difficult by understanding during training, this is what I was taught, and now I'm seeing a new thing. How do I now bring to bear the use of new technology to meet the patient need? We have limited simulation-based learning. In Nigeria, it is a commonest problem that it is now that the government of the Federation is taking a look at it. Sometimes you move around the teaching hospitals and learning institutions. The simulation labs are not there. While you have the simulation lab, the clinician that is already practicing, where a new technology is being introduced, will go there to refreshing, or the student under training could move to that place from the skill lab. I've been taught that this is the way to do it. I've been told that the procedure takes these following steps, but in the real life practice, before I get exposed to endanger patient life, let me go to where you have a high fidelity mannequin to practice, so that it could improve my knowledge and skills. At the time I'm at the clinical side, my interaction with my patient will be very mutual, and many of the mistakes could be avoided because I've passed through this simulation, I've practiced it, or the clinician that is there is going to do the practicing in the simulation lab, so that by the time he or she comes to engage with the real life situation, he or she may not find it difficult. Well, it's a common thing that we have inadequate clinical skill laboratories. The training institutions, acquiring the new models, the high fidelity mannequins, has been a challenge. Here, let me recognize very importantly the support of WHO, Gate Foundation, that many of our training institutions, nursing training institutions today, are receiving support from them. They identify institutions, they did the need assessment, and supported these training institutions to bring them up by the government of the state-owned institutions. Not many of them have this required equipment, but many of them will be able to acquire them now and using them to teach their students. Insufficient exposure to high fidelity simulation. I've talked about it in the course of the other part. We have ineffective clinical supervision. This is one area that Council has strengthened now. We have requested the hospitals to identify faculty people who will be preceptors, and we brought them to a gathering, train them, and have a formidable team of preceptors. We refer to them as national preceptors, that in the course of training, they engaged the student at the clinical side, while the clinical instructors did their best at the institutional level. The two of them, especially the preceptors, the hospitals are supposed to recognize them not only for the training of the student. The education unit of nursing division should be able to use these people as facilitators who should regularly be teaching the clinical staff on how to use modern equipment. But it hasn't been all that available before, not until council brought in the preceptorship training that will now have a team referred to as our national preceptor team, that in wherever or in whichever hospital the students are going for practice, they are there. It will just be that we will expand it to ensure that almost all the hospitals should have them, so that with the new technologies and advancement, or by the performances of the nurses in the hospital setting, they should be able to use them to enhance knowledge and skills of the nurses. Next slide. Courses of theory practice gap. We looked at it from this perspective: inadequate clinical hours during clinical posting. That is for the student. Earlier on, I had said that because of, number one, they have an assigned time they are to spend in the clinical setting. And while they are there, because they are not standing on their own, they are under supervision. They are commonly just mere observers and have a limited time to do a hands-on skill practice. In doing that, they may just do it once or twice and then return back to the classroom setting. While in the school, the skill labs they have, well, some do have equipment, some do not have. So if there are no adequate equipment, the practice will be limited. We have human resources capacity gaps. One is shortage of clinical current educators. We know very well that the faculties are supposed to have, or to also take time in going around the clinical sites to engage the clinical staff and share new knowledge with them. But because the school activities is engaging them and we don't have enough hands in the clinical side, it becomes a problem that, the new technology that is being introduced or the emerging disease that is coming up, the handling skill of that situation, not many are available to give orientation on to others. The desire or by the turnover of the patients sometimes engage the nurses so much that they find it difficult to step aside to do some other responsibility aside the primary ones given to them. But going to acquire this new knowledge will be more beneficial. But if he or she leaves, who covers the ward because of shortage of staff? Limited educator exposure to current clinical practice. Well, you may have the knowledge to do, but the equipment to use, if they are not there, how then do you use it to teach? And that is why the need for simulation lab, as it is being done now, is very necessary to cover the gaps that is being created by this. Next slide. Lack of structure preceptorship, that was then. Now that we have identified and we have trained a group of people that are there, though not adequate, but at least in the training hospitals, we have as a few of them around to help guide the student and the staff that are in the ward setting. Staff shortage and workload. I have just used it to explain the last point before the one I just finished talking about. poor clinical learning environment. It is a common thing that you go to a hospital. In the same hospital, where you expect a better performance, they don't even have a continuing education unit where people could even go, or where after assessment, challenges are identified and educational planning is designed to enhance or improve the clinician's knowledge and skill. But you don't even have that environment where you bring people to, except probably you send them out. But in sending them out, you already have shortage and there's heavy workload. So who covers? Those are some of the reasons that are giving rise to this theory-practice gap. Regulatory and system factors. The regulatory standards are set, but by the available either manpower or equipment in this clinical setting is difficult to meet up, because either by shortage of manpower or lack of equipment. We have seen in many hospitals. In many of the hospitals, you go, you see improvisation every now and then. Go to number one, let us start from bed making. You go to do a bed making, there are a number of bed sheets that is required to do this bed making, but you see that the client or the patient is the one bringing him or her own bed sheet, spreading it on the bed. And from there, you see lack of uniformity. All these are factors that affect the performance. I want to do it, but what I will use in doing it is not there. And this is the standard set by the regulatory body. Such are issues that often lead to this theory-practice gap. Limited integration between education, regulation, and practice. Well, like I have just tried to explain, the standards are set, and in the educational institution, the equipment are either available and the students are able to learn with them, but when they get to the practice area, they don't see it to use, or they are available in the practice area, but the training institution don't have them. You see students begin to move from one end to the other, trying to say they should go into the clinical side to try it. But again, the ward officer is cautious of what the government will say that they are under his or her care. So after the official closing hour, releasing it for the student to use becomes a problem. Well, weak enforcement of clinical training standards, this is why it is happening, because all of these are not there. Even the officers that will do, how many in the time past, an officer who has attained the level of senior nursing officer, where you have them plenty, are assigned a higher responsibility. But because the workforce is so limited now, you see that the person that is supposed to do a supervisory work is primarily engaged in handling the basic work that the junior nurse will have ordinarily done. So it becomes difficult that, okay, to maintain these standards, nobody is there to probably supervise what the younger one is doing. And to that, he or she is bound to make mistakes that affect the patient's safety. Inadequate monitoring of CPT effectiveness. This is another factor. You expect that a staff who undergoes the CPD should have improved knowledge and skills, which he or she will bring to bear in the clinical setting. But number one, how many people participated in this CPD? And then who has the desired skills and knowledge to supervise the implementation by others? So you notice that the monitoring of the CPD knowledge acquired is limited, and to that extent, it will not enable effective performance. Limited access to current clinical guidelines and research. This is something that should not be, but even the journals that are there, you go to a hospital, many of the hospitals, they don't even have the hospital library again. You go online, the workload is not even giving you a chance to make attempts using your own data to say, let me access this information online. Even if you are able, how many times do you have to read to the end? Where do you see the actual demonstration taking place? Some of these are challenges that is making it difficult for our creating the theory practice gap. Next slide. Then the danger is, what are the impact of this theory practice gap? The impact on patient, the impact on nursing workforce, and some other things. Because there is this gap that is being created, there will be increased risk of medical errors. I'm new, nobody is supervising me, or I'm a student, nobody is mentoring me, and I'm asked to do it alone. I'm bound to make mistakes. And with that mistake, it is very dangerous on the patient, particularly because it will cause a lot of issues. Reduce patient safety, like because of the medical error that is committed, patient safety is at risk. The inconsistent quality of care, the theory practice gap that created, the gap created, will probably Nurse A will be able to do it this way, but lack of understanding by Nurse B, the practice may not be the same. Or in Hospital A, where you have enough equipment and adequate manpower, they are able to effectively do a procedure. But in Hospital B, who is suffering from lack of all equipment and shortage of manpower, the practice is not similar. You go here, you say, but the way we were handled, the way we were treated in the other hospital was far better. Oh, you are doing better here than the other hospital. All these are the impact of the theory practice gap. Impact on nursing workforce. There's reduced clinical competence. I've given so many reasons why that should be. Low confidence among graduates. I'm just exposed. I'm taking responsibility for the first time. I'm not used to doing it. Therefore, the confidence is not there. Supposing during my training, I have enough time to practice it by myself, it will have been better. But I have limited hours as the training time. Now that I'm here alone, except I dedicate my time to visit the simulation lab, which is also not available.
Sorry, sir, you have 10 more minutes to
begin to manage
so that we
to
can
see
also
that
take
let
the
me
questions.
improve my skills on the job. But within that period, it is so dangerous. Increased workplace stress. This is what nurses suffer. A lot of them come to work on their foot from morning to the closing time, and where you have high client patronage, you don't have a resting time for yourself, which is also dangerous. As you care for others, you need to care for yourself. Not having adequate time to rest may cause another burden on the nurse, him or herself. At the end, it will translate to reduce patient safety or may lead to medical errors because I want to meet up with client A, client B. I'm attending to this, and then somebody is shouting us there. I'm midway handling this patient condition, and I'm alone. While there's a patient with severe pain shouting, debating for my attention, I had to abandon this to attend to the other person. Next slide. Mr. Moderator. Impact on health system. Generally because it affected the nurse. It affected the system. Now there's reduced healthcare quality. I want to do it well, but I don't have all that it takes to do. I also want, because of the errors committed earlier, what patient is not supposed to buy twice, or the danger earned by the medical error has led to another thing, making the cost of the treatment increase due to these errors that have happened in the past. We have reduced public confidence in healthcare services. Where you don't have an elite who understand very well that, oh, this is a new person, this is that person, the confidence is lost, the trust is not there. I cannot go to that hospital because the performance is like this. It isn't the performance that is bad, but the system generated errors or impact is what is giving the impression that the public does not have that confidence on the system to say, and that's generally why you see medical tourism happening. In Nigeria, people travel a lot out. The commonest site we hear of these days are India and Egypt. People travel there every now and then. They'll tell you go there, you are treated within a specified period of time, simple because of new technologies and efficient service render. Locally, you want it done. You have the knowledge, you have the skill, but then nobody is there. Yes, go ahead with the next slide as projected. Now, bridging the gap between theory and practice. Next. Now, innovations should take us to a new way of bridging the gaps. I have learned theoretically in the class. I'll now use the new knowledge or the new environment to perfect my practice. And to that, we needed to do a crossover. I'm translating now from studentship to a practitioner. And in the practice area, or I'm perfecting my practice from a novice to an expert now. That is the essence of saying the bridge there. I have to cross over. I have spent a time, at least 5 years in the setting. By now, I should be perfect to be able to give orientation to some other person again. Next slide. Strategic roles of the Nurse and Midwifery Council of Nigeria in theory practice gap. The council plays a statutory role in regulating nursing education, to which everybody knows. It accredited nursing training institutions, regulates continuing professional development, then maintain professional standards, as it is uniquely positioned to lead national reforms in order to bridge the gap. In essence, what we are saying here, they are straightforward language. The act that established the country empower it to regulate its education and practice nationally. But then the foundation of doing those services is that where are these training going to take place? It is a certified nursing institution by the council that can effectively, or that should be empowered to do the training, regulating continuing professional development. The desire, that's why we often take a feedback in the council. We go around to see, and by judgment, you see that sometimes during examination, institutions training the student by their clinical skills during the examination, the report, the feedback we get from the examiners signifies doing. We have also said that in the clinical sites, we are beginning to urge them to say they should engage in research work and be able to give us a feedback. What are they doing? The curriculum, how effective is it? And then what are the challenges that those that are in the clinical side are not being able to meet with? The student feedback after posting that they return back to school, they say, oh, what you taught us with this in the classroom setting, we go to the clinical side, but we are not seeing it that way. So in us identifying the areas of concentration for continued professional development, we rely on feedbacks. We maintaining professional standard. That is the function of the council, both in training and in clinical practice. We need to lead the national reforms in order to bridge the gap, because it is the main responsibility of the council. No other person can do it for us. But while we do that, we set the national standard and we expect everybody to buy into that. Next slide. Next slide. The three pillars of bridging the gap is that pillar 1, strengthening nursing education; 2, enhancing continuing professional development; and employing evidence-based practice. So we'll look at them one after the other as we move along. Next slide. Strengthening nursing education. Curriculum reform. Regularly, we in the council review curricula of all the programs every 5 years. Here again, let me appreciate the WHO, the GATE Foundation, NANAGACE, and some other partners who have supported council to do the review. Many of recent, many partners have come to the council. They have taken responsibilities to support us to do this review, which is like that of the NDHND. We have just finished reviewing, but we are already setting a date for validation. We expose it to critiquing, so that people could tell us, yes, it is like this, it matches with the system, and where necessary corrections need to be done, we are working on it to ensure that we do that. Integration of competency-based education. Like I said earlier, I said competency is still just about knowledge, skills, attitude, and performance, the behavior. All this we bring together to ensure that what we are going to teach captures the mode, that is the cognitive environment, the affective domain, and the psychomotor skill of educational domain are brought in together to ensure that the person we are preparing is competent enough to serve in each level of or tier of care, be it federal, tertiary, secondary, or primary level care. Integration of evidence-based practice principles. We notice that you go to one environment, you see the practice like this. You go to the other, you see the practice like this. You go to one other environment, you have a different way of approaching, but then the goal is the same. In order to effectively do it well, we develop National Procedure Guide for Performance. In this National Procedure Guide, the underlying principles of performance are stated, such that where now it is already been circulating in the training institutions, in the clinical sites, everybody should have it to see that this is the way it's supposed to be performed effectively. And to that extent, we are making it a nationwide directive for all the hospitals and the training institutions to acquire one or two for their own hospital to guide their performance. Inclusion of simulation-based training. The curriculum we review, we are looking at it much that we have more simulation centers now. Everything should be is inculcated in the revised curriculum that is due for validation. Next slide. Strengthening clinical training. We structured clinical learning objectives, mandatory clinical supervision framework, and standard clinical logbooks. The three of these are identified and established by the council to ensure that the purpose of sending people to the clinical side, we have directed institutions as students are going, identify your objectives, send it to the clinical side, let them understand what the main objective of sending them for that period. The last time I was sent, meaning at my first year's second year, I'm expected to be oriented into the basic care. Now that I'm at a senior level, I should begin to do some certain functions that will exhibit my senior level, that I'm entrusted with a more responsibility that I should take I should be responsible for every act I'm going to do at that level, so that as a potential nurse, if I qualify, my performance shouldn't be a challenge. Mandatory clinical supervision framework. Those are designed and it is attached to the logbook. You see that in the record of instruction from the clinical, from the training institution down to the skill lab, and then moving to the clinical site, it is recorded the number of hours, the expected performance, and how many am I able to do effectively. I should be rated, and then a report given back to the training institution. While the person doing the training, that is the preceptor, look at the guidelines given to him or her as a framework of supervising. So they work hand in hand. The supervisor has a laid-down framework, while the student under training has a logbook to checkmate what he or she has learned, that will at the end be used to judge him or her before qualifying. Next slide. For us to strengthen the nursing education, curriculum alignment with clinical realities.
Sorry,
Nursing
sir,
curriculum must be competency-based rather than purely content-driven. Like I said earlier, if I will put into the curriculum mere knowledge that will not translate to exhibiting competency at the clinical side, then it is not clinically oriented. And to that, the people that will train under such an environment will find it difficult. They are most to be exposed to these theory clinical gaps that have been mentioned earlier. Competencies should reflect the real clinical demands, critical thinking, emerging response, interprofessional collaboration, digital literacy, and ethical reasoning. This should be what the competency should reflect. I've just been shouting it under the form, under the other headings. definition of what the competency should be. A regular curriculum review in collaboration with clinical stakeholders ensures alignment with academic preparation and service delivery. I have talked about it. To that extent, Council is a game changer in the aspect of regular curriculum and the regular curriculum review in partnership with clinical stakeholders. Next slide. Next, simulation-based learning. Simulation laboratories, high-fidelity mannequins, skills lab, and scenario-based training allow students to rehearse procedure before encountering real-life patients. Those were the things we identified earlier. And for us to effectively do it, it has to take this pattern for us to be able to ensure that the errors or the gaps are limited and the errors committed in the clinical side are very much little. Simulation enhances psychomotor skills, decision-making, and confidence while protecting patient life. Structured debriefing after simulation promotes effective practice, which is essential in translating theoretical knowledge into clinical reasoning. Yes, this one takes place in the simulation lab. It is good that practitioners or students appear to give a return demo of whatever they have learned. After that, let there be a feedback immediately indicating that by your practice, you were able to do it well like this, but the other time, but you saw the patient reaction. And to that, while you are doing it, you are supposed to do it like this. It will help build up the nurse that at the clinical site, he or she might have limited errors. The Council recently received generous donation of simulation equipment from Gate Foundation, and like I said, WHO too supported. Many of the institutions have this equipment with them now, and we expect that there will be a better performance of the graduate of those institutions. Next slide. Development of human resources, continuous training for nurse educators, clinical refresher programs for educators, support for postgraduate education, advocacy for continuous capacity building of faculties. All this aims to improve the knowledge and skills of the trainers, that is the academicians and the senior clinicians and the preceptors that will handle the student or guide the performance or mentor the performance of the newly employed nurses. Next slide. Strengthening continued professional development. The importance of CPD is that it ensures that nurses remain clinically competent, updated with modern practices, and professionally accountable. These are straightforward languages that explain what the CPD will do for the nurses that undertake the courses. Next. The role of continuous professional development, what I've just said earlier is what is being spread out here. One is lifelong learning. CPD fosters lifelong learning among nurses, ensuring that they stay updated with the latest evidence-based practices and advancement in patient care. It also enhances skills by engaging in CPD activities. It helps nurses to enhance their skills and adapt to new roles, ultimately improving healthcare delivery and patient satisfaction. Networking opportunities. It often facilitates networking and collaboration among healthcare professionals, leading to shared knowledge, improved practices, and mentorship opportunities. This will be much done if we have collaborative performance, the people, all healthcare officials, irrespective of the profession they belong, there should be a common point where everybody comes and give a case study. A scenario is created. The doctors made his observation and prescription. The nurse performs his or her duty, all towards saving patient life. At this point, it will be seen that, oh, by your performance, doctor, this or your observation, or let me or let me remind you of this, that the patient is exhibiting. You were not here yesterday. This patient demonstrated this, and by my record, we need to take care of this. The doctor says, yes, thank you for what you did yesterday. It helped the patient, but you could have done it this way. It will foster patient recovery. There, they have collaboration. They have a mutual understanding and improves skills of patient outcome. Next slide. Strengthening CPD regulatory enforcement, expansion of online CPD platforms, which we are doing now, structured national CPD framework, mandatory competency-based CPD. All these council has put into consideration. We are beginning to do a hybrid CPD. You learn virtually, and then we have a common point where everybody comes to demonstrate or practice the skills for perfection before you are awarded the required credit unit that justify that you have really understood the message. But before we do that, there is a structured way of handling it. Whoever is to do it, this is what we expect of the person. Next slide. Next slide. Promoting evidence-based practice, integrate best research evidence, clinical expertise, and patient preferences. Evidence-based practice improves patient safety, quality of care, and clinical outcomes. The Council has ensured that the evidence-based practice is integrated into all curricula of nursing specialties. Access is provided to research databases. Clinical, in fact, here, the Nurse and Midwifery Council of Nigeria is embarking on a new move to support the training and clinical sites by establishing, the council is already on the process of establishing a central e-library that will give access to all the learning institutions, the clinicians, that for whatever information or learning resources they want, they could reach out to the central e-library and be able to gain knowledge. To foster it, the e-skill lab is going, a central e-skill lab is also going to be established already by the new National Procedure Guide. Each procedure that is stated there, we have tried to provide a link, although not to all the procedures. In many of the procedures, we have provided a link that after reading, understanding it or not, you click onto the link, you see what is expected. It is being demonstrated for you to effectively learn your expectation. Clinical research participation is encouraged. Like I said earlier, Council is trying to make it mandatory for all nurses in the clinical side for each hospital to draw up on one research work that will be submitted for evaluation by the council. Equally, the training institutions will compete and be able to demonstrate. It is in line with that we are partnering with international organizations that at the end will establish a digital classroom that will talk about or teach more on research studies and further make assessment of what is being done locally, so that wherever there are mistakes, we could easily correct them. National procedural guideline is developed. I've talked about that. Next one.
All right, sir. Can you hear me, sir?
Yes, sir.
Okay, sir. You have 3 minutes to round up so that we could be able to take
I'm
questions
almost there.
from the house.
I just have a few slides more.
All right, sir. All right. Thank you, sir.
Next slide. Okay. This synergistic framework is something that people could read easily and understand. Next slide. Next. The way forward. What are we to do to ensure that the theory-practice gap is minimized? One, foster collaboration between academic institutions and clinical facilities, invest in simulation and digital learning infrastructure, strengthen preceptorship framework, promote research engagement among practicing nurses, and encourage regulatory and institutional policies that prioritize competency over mere certification. Next slide. What are the next steps expected to be done by the Council? Council, being the sole regulatory body, should strengthen CPD regulatory enforcement, establish national clinical preceptor framework, promote evidence-based practice nationally, strengthen accreditation and monitoring system, promoting academic clinical partnership. Next. The summary of all that we have said is that when theory informs practice and practice refines theory, then the profession advances. The bridge between theory and practice is built deliberately through education, reflection, research, and leadership. Ultimately, when the nursing education aligns seamlessly with the realities of the world, the result is a more resilient healthcare system, more confident clinicians, and more importantly, better care for the patients who depend on them. Yeah, next. In conclusion, bridging the theory-practice gap is essential to strengthening nursing education, improving patient safety, and enhancing healthcare outcomes in Nigeria. The Council has the leadership mandate and regulatory authority to drive transformative reforms that will ensure Nigerian nurses are competent, confident, and globally competitive. Yep. Thank you.
All right. Thank you so much, sir. Thank you for the in-depth presentation on the 21st century nursing practice, on issues surrounding it and ways of bridging the theory-practice gap and strengthening nursing education in Nigeria using evidence-based practice. We thank you so much, sir. So we'll quickly open the floor so that we can take questions from the audience. We have over 400 participants in this presentation, in this webinar today. So for those who want to ask questions or comment, kindly type your questions or comments and drop at the inbox. We'll read it out so that he can quickly take it before we round up. Thank you so much. You kindly have about 2 minutes to do so that we can take the questions. Okay. Okay, sir. The questions already coming. So maybe I'll read out the questions you can answer. So the first question says, does the council organize training for preceptors in various hospitals so as to make them all be on the same page? Can you hear me, sir?
I can hear you. Council does. The first set as the people we train have stayed for 5 years. We are arranging to train the next set. In that wise, all hospitals will be invited to participate. Next.
Okay. I think there is a follow-up to it. He said, is this training done simultaneously so that all the hospitals will be on the same page?
It will be done regionally, the geopolitical zone. We will organize in the 6 geopolitical zone. Those in this area will have their own the first week, and then in sequence like that, we will reach out to all the regions so that everybody will be on the same page.
All right, thank you, sir. The next question from Olubumi Lawal. He said, how do we create a synergy between preceptorship and mentorship? Did you get the question, sir?
I do.
Okay.
The preceptorship and mentorship. The number one, I had in the course of this presentation mentioned that the preceptorship framework has been developed by the council, and in using that framework, he or she that is to mentor is supposed to follow the pattern so that wherever the trainee is, you see that the pattern is the same, and that will then enable the trainee follow the pattern of the mentoring to ensure that wherever I find myself, since they are using the same framework, a national guide, the performance will be the same. Thank you.
All right, thank you, sir. This one I think is a comment. I don't know whether it's a question. He said, from Joy Iwoha, he said, so many students don't come for the clinical postings and they still pass or graduate. Why is that?
Well,
if students don't come for clinical posting, but they still graduate, why is it that?
Except the confidence entrusted on the institutions and the examiners is being derailed. If not, but number one, that is why we have Viva during examination. The examiner is supposed to collect the clinical experience book which is the logbook from the student, go through it, see where the school environment, where the lecture takes place, the skill demonstration takes place, and the clinical side where the performance is supposed to take place. From there, the student may be able to partake further in the examination or not. By whatever they see there, it justifies that the student did not go or cover up the clinical training hours. That is one. The training institutions are supposed to report back to the council. Council cannot be everywhere. Although we have established zonal offices to monitor implementation of policies, they may be limited. They have so many hospitals to cover. If they did not see, we have what is known as state nurse and midwifery committees who are supposed to support the council in checkmating activities, policy implementations, and supervision of student training. Let me call here that people under the federal institution should not see the state directors of nursing services coming into their facilities for monitoring as their enemies. They are partners in progress. They are there to represent the council, checkmate what the students are doing, and equally what the clinicians are doing. But where you have rivalry between these institutions on the claim that I belong to a tertiary health facility and you are coming or you are representing a state, you don't have authority over me, it will not help us develop. So it is my call to everybody, one, to the student, to the school, that students should be monitored during their clinical practice. The the clinical instructor and the preceptor should work together to monitor the punctuality of the student, performance of the student, and report otherwise. Equally, the examiner who goes to examine should be able to report to the council that viewing this candidate failed because he or she did not meet the requirement of practical hours. That is why he or she fails. That should be done. Institutions should collaborate and support the council by allowing a peer review. The state is coming to check, or the people at the federal level that are appointed as members of State Nursing and Medical Committee, when they go to the state level should cooperate with them. That is the best way to do it. Nursing and Medical Council of Nigeria is just a body located in one side, cannot be all over. But we have taken measures. At least I have said about 4 steps that needed to be done to ensure that student training is entirely covered. Thank you.
To send this slide to me. All right, thank you, sir. There are more questions. A lot of questions coming.
I'm waiting.
See how we can take all of them, or at least most of them. So one of the questions from Olubimi Lawa Aiden, he says, can those of us in the private sector, can those of us in the private sector serve as preceptors for the National Midwifery Council?
The preceptorship, equally the people serving in the private sector, it will be difficult for them to come in. But where they don't have a good hand representing the facility, if we train and we find that the performance of the person in the private sector is more better than that of the person in the public sector, we have no choice than to allow integration. Thank you.
All right, thank you, sir. The next question from, okay, his name is anonymous, no name on his handle. He says, are the private open universities offering direct nursing sciences that is recognized by the council?
No.
Okay, sir.
No, they are not.
Okay, sir. So the next question from Aliu Shehu, he says, what measures has council put in place to make sure compliance of clinical training is 100%, or compliance is 100%?
I've just mentioned them now. Earlier, I've said that. Yeah.
Okay. Another question, I think, is a comment. It said, instead of opening more of nursing schools, why not strengthen the existing ones to be more stronger?
I wish to announce to the public that under the permission of the federal government, we have placed embargo on establishment of more training institutions, and even the existing ones, we are going to check them and then rank them to see that those that did not meet up with the requirement steps aside. Thank you.
All right, thank you, sir. I think there's a comment from Aminu Omobolo. He said, how can the Federal Ministry of Health support adequate recruitment of nurses at the primary healthcare centers so that student nurses are not directly being supervised by lower cadres? I can't really get the last question, but at least he said
what he or she is trying to say. She is trying to say that we realize that in most of the primary healthcare centers, the people that take control are community health extension workers who do not have the clinical skills required for training of nurses. To that extent, we have gone to reach out to the National Primary Healthcare Development Agency. I have spoken with them over the engagement and even establishment of a nursing division in this sector so that we could have more nurses employed into the centers that will take care of training or that will engage in training not necessarily engage in training for better health care outcome. Thank you.
All right, thank you, sir. Then this is a comment from Ezenwumba Clement. He said, mine is a request that there will be organized workshop on stimulation because so many institutions do not have that, and many clinical instructors do not have knowledge on that.
It is because of that I am embarking on establishing a central e-skill lab where simulations and other practical performance will be demonstrated. And we want to make it very friendly that you get into it at your convenience. Where you have questions, the lines will be provided to enable you to interact with somebody that can give you a further clearance on what may not be too clear to you.
The next question says, why are the preceptors not being paid? That's from Jacinta Egon.
Okay. The issue there is that we know what the nation is passing through, and I'm not the employer, but NAM will capture it in their quest to the federal government to give recognition to these people so that they could be paid once the federal government approves that. Thank you.
All right, thank you, sir. Then I think this should be the last we'll take from Zubaidu Mohammed. He said, what is the council doing to ensure that the clinical preceptors receives adequate training and certification?
I have said that the last batch that we train have stayed 5 years. Now it's a period to train a new set. And right away, the education department has make arrangement for that. The date will soon be announced. But like I said, it will be done on regional basis, on geopolitical zone, so that we have an organized number at a center that everybody, where need be, to do a return demo, to exhibit dexterity in the acquisition of skills, will be done in that order.
Okay. All right, thank you, sir. There are two questions that are important that just popped up. Maybe we'll just read the two out. If you can respond, that would be wonderful.
If you have more and there is time, we can do more.
Okay. Thank you so much, sir. This is an interesting topic, and I can see many people are interested in getting feedback from you on some of the gray areas they have. For those online, please, you can click on the link being shared to fill in your attendance too. For Philip Eteng, is asking, in the aspect of developing human resources that has become challenging for those of us in the clinical setting, how can nurses in the clinical settings know the authentic/approved online centers for postgraduate programs for human and skills development in the nursing? That's how can they know the authentic/approved online centers for postgraduate programs?
That's what the Department of Standards and Accreditation will include that in its information to the public. You can check through council's website. All the approved centers by the council will be included and will be displayed in the council's website. Thank you. Okay. Next.
All right, thank you so much, sir. From Ben Udeme, he said, please, what strategy does the council use to ensure that knowledge passed during the CPD are current and relevant?
I have told you that we get a feedback on the performance and in the clinical settings, and that informs areas of development. It is not just that we sit down and just bring up anything. It is when we have a report, a consistent report and a pattern, that there is a challenge here, that we look and develop the CPD on that pattern, so that it is not just one regular course that you come to attend. It is aimed at developing and updating knowledge and skills. So it should not be a consistent one pattern or one topic. it is as the needs, the demands come up that we lay emphasis on it. Once somebody has used a curriculum for training, it is expected that in the clinical side, the person should be able to demonstrate competency, but where it is a challenge and we have a feedback. That's why you see this administration from the beginning, we make a plea to the public that the administration is asking for 4 things. One is that we need people to support the policies. How do you support the policy? If you understand the policy release, imbibe it and act on it. If you don't understand, get back to the council, ask for clarification. We will tell you that. 2, we said we need prayers to get more wisdom to enable us improve in the service delivery. 3, we need objective criticism of what we are doing. If you are not satisfied, tell us your areas of concern and do not just challenge us, give us a way forward. We will review and look at it. If it is something we have thought over before, we could answer you to say, oh, we have tried this and this is it. But if you're on it's a new way, we could try it and see how well it will be. Then the last one, we ask people to give us innovative thinkings that will enable us forge ahead. Those are the requests of the administration, and we have been responding to those who felt or those who have written to us. We have been getting back to them. Thank you.
All right. Thank you so much, sir, for in-depth analysis and feedback from you. We want to thank you so much. You've really done justice to the topic. And for our audience, at this point, we'll draw a curtain to the questions session so that we could take the closing remarks from the Director of Nursing Services, Federal Ministry of Health and Social Welfare, who is standing in for the Director of Hospital Services. And she's no other person than Uma Bong. Ma, you can kindly unmute yourself to give us the closing remarks for this series.
Good morning, everybody.
Good morning, Ma. We can hear you.
Dr. Ndagi Alhassan, I really appreciate the topic you've given to us. On behalf of the Honorable Quality Minister of Health and our dear PMSEC, our Director of Human Resources, I'm Director Planning and Research and Statistics, and my mommy, Director of Hospital Services, and Dr. Adegoke. I want to really humbly appreciate our own registrar, Dr. Ndagi Alhassan. The topic, bridging theory-practice gap, strengthening nursing education, continuous professional development, and evidence-based practice is very, very timely. I just wish we would have more of this often. We really know that our nursing and midwifery council, they are not just there, only regulating policy, but they have a lot of things to improve nursing education in the country. And I bet you go anywhere in the world, Nigerian nurses are the best because they receive the best training, both theory and practical. I want to appreciate all my nurses nationwide that find them even outside the country to attend the webinar. And I believe you've all gained something. Thank you very much, the Department of Planning, Research and Statistics, for coordinating this webinar. We really appreciate you all. Thank you. God bless you all.
All right. Thank you so much, Ma, for the wonderful closing remarks. Oh, thank you for being there for the Nursing Council and the nursing training in Nigeria. We also thank immensely the Chief Registrar and Chief Executive Officer of the Nursing and Midwifery Council of Nigeria. I will thank our wonderful audience and participants who have joined this webinar series. So at this point, we would want to draw a a close to the series today so that we all can go back to our official duties. But we also want to say that quickly click on the link to fill in your attendance to register that you participated in the webinar series. And as we would want to round up, we also appreciate our Director, Health Planning, Research and Statistics, our amiable director, who has been elevated to a Federal Permanent Secretary for piloting this webinar series and giving it the life since his time at the Department of Health Planning, Research and Statistics. And we hope the webinar series will always continue, even as he leaves us to his new assignment as a Federal Permanent Secretary. Thank you, sir, and thank you all for participating. Kindly sign the attendance, and God bless, and have a wonderful day as you continue your day. Thank you all.
Thank you.
Thank you, our moderator. We appreciate your work.
All right. Thank you, ma.
Well done.
Thank you, sir.
God bless. Bye, everyone.
All right. Bye-bye, ma. Bye.